Hi everyone, today we are talking about individual and group interventions with socio-emotional and cognitive challenges with older adults, things like depression, anxiety, and dementia. This first part of our discussion today is going to focus on individual treatment options, and then the second part will deal with group intervention options. When thinking about individual therapeutic interventions, we want to remember what the primary goal of an intervention is, right? So in general, the goals of therapy or a therapeutic intervention are to change or adjust to a situation. So that could look like decreasing symptoms, maybe symptoms of depression or anxiety. It might look like reducing risk of relapse, or maybe preventing something from happening that you don't want to happen again. It might be improving medical health status or increasing perceptions of quality of life. It might look something like decreasing healthcare costs or mortality rates, or it could look like fostering empowerment. Sometimes, despite our best intentions, there are still obstacles to intervention and treatment with older adults. Some of those obstacles include the absence of suspicious events or the lack of routine observations, things like missed work days or a job loss or excessive sick leave. These are things that would be noticed in people that are probably still in the workforce, but for an older person who's maybe retired, those would be things that would be less noticeable. It might also involve less community connections or less engagement in the community, where people are, encountering fewer people on a daily basis, and there's no one to really be accountable to. So it's easy for those kinds of suspicious events to be overlooked. Another obstacle might be the confusing or mistaken factors of cognitive effects and competing health problems, often producing similar symptoms. For example, we talked previously about the 3Ds, dementia, depression, and delirium, and how a lot of times those symptoms overlap with each other. So it's really important to have differential diagnoses. And when that comprehensive geriatric assessment is not done that includes differential diagnoses, that contributes to these confusing and mistaken cognitive effects or competing health problems. Another prospective obstacle for treatment and intervention with older adults is that oftentimes primary care providers themselves have lower functional expectations of older adults, which obscures accurate and timely diagnoses. Even professionals often associate things like symptoms of depression or memory loss as a normal part of the aging process, and a lot of times older adults do too. So when there are issues maybe around memory or sleep problems or fall issues or driving accidents, they're often seen as aging-related issues and not necessarily perceived to be an issue with an older adult that is worthy of some type of therapeutic intervention or treatment. Another issue is sometimes the difficulty in conceiving of an older adult having a substance abuse issue or being taken seriously about any suicidality. Older adults are less likely to be screened for these kinds of issues by their primary care physicians. We also know that ageism exists even within the health and human services system. So attitudes about aging influence perceptions of older adults and lead to unfair and detrimental stereotyping. For example, some stereotypes suggest that more educated or higher socioeconomic status or being female as an older adult means that you're less likely to struggle with issues, and those issues are less likely to be detected. In part, that's also a result of the fact that as people age, their primary care providers spend less time with them during exams. So again, they are less likely to be screened for specific issues because there is this idea that older adults don't struggle with certain issues and therefore don't need treatment for them. Healthcare providers also have doubts regarding efficacy of treatment and interventions for older adults. Sometimes they feel that nothing can be done or nothing will change with an older adult because maybe they're set in their ways, so they're less likely or less inclined to offer suggestions for a treatment or some kind of intervention. Another obstacle to treatment sometimes is related to cultural barriers, which can also be connected to health literacy. Examples of this might be with regard to some health or mental health issues, the way in which some cultures associate those issues might be related to the etiology of those complaints. So, for example, some cultures might think of certain illnesses as being something that they are dealt with or have to suffer through because of something that happened in the past with previous, maybe sins or previous behaviors or decisions that were made. And because of those previous actions, they are now meant to be punished for that. So if that's the belief of the etiology of a mental health issue or a physical ailment of some kind, oftentimes people will be less compliant with treatment options or interventions that are offered that might be helpful to them. So how they think about whatever their struggle may be definitely impacts how compliant they will be with any recommendations for assistance. Health literacy refers to the idea of really understanding what information or instructions might be given. So for example, if a doctor prescribes a medication of some kind for a health or a mental health condition, do we really know that the instructions for taking that medication fit with the mindset and the lifestyle and the daily experiences of the older adult? For example, if a prescription is provided that says, take this pill 3 times a day, with meals, so assuming that a person eats breakfast, lunch, and dinner, then the assumption would be they would take the medication with their 3 meals. But what if a person doesn't eat breakfast, lunch, and dinner? What if they skip breakfast and only have lunch or dinner? Or what if they only eat once a day? And so to tell somebody to take the medication every time they eat might not fit with a lot of older people because they don't have that traditional sense of eating times or meals that is kind of a common general idea of what meals and meal times look like. So that can be problematic because if they're not taking their prescriptions as prescribed, they're not going to reap the benefits of that medication for whatever they're taking the medication for. So making sure that older people that we're working with are health literate, whether it's about a medication or about nutrition or about exercise or other lifestyle habits or whatever the case may be, is really important to ensure the effectiveness of an intervention. So I mentioned a few moments ago that when we think about individual treatment or intervention with older adults, we probably think of traditional therapies, things like these modalities included on this slide. I'm not going to read through all of them here as I have more information on them in the next slides, but I do just want to recommend that the link on this slide is a video that I think is a good overview of traditional therapeutic interventions with older individuals, especially those that are experiencing mental health issues like depression or anxiety. And so this particular video, if you watch it, I believe it is about 30 minutes long, and I think it gives you a very good overview of some of these kinds of interventions and what issues they would be used for with this population. Okay, so when we talk about interventions and treatment, the traditional therapeutic modalities, and specifically referencing depression and anxiety and dementia, this slide is showing what approaches have been shown through research to be evidence-based treatments for depression and anxiety with older adults specifically. And again, I'm not going to go through all of these specifically, but there are some that I am going to talk through because I think it might be helpful for you to have some refreshers and maybe tie some of this information in with other courses that you've had in your MSW curriculum. So things that relate to practice with individuals and maybe your mental health practice course. And so this is just a very brief review and overview of some of these. For the ones that I don't talk more about, well, actually for all of them, I have a link there. These are all very short video clips. Some of them are role plays, some of them are descriptive and informational video clips. Some of them are examples of what this therapeutic style might look like. So they're each a little bit different as far as what information they might be giving you, but they're also fairly short, maybe 5 minutes. Some of them are a minute long or a minute and a half, and some of them might be 5 or 6 minutes. And maybe on a couple of the slides there might be 1 or 2 links that might be longer than that, but by and large they're less than 5 minutes long. So I encourage you to do a quick review of as many of the links as you can, but I know that you don't always have time for all of that. But if you're wondering about more information on any one of these therapeutic approaches, I do hope that you take advantage of watching these short videos. So there's behavioral therapy. Again, this is evidence-based, and there are some different styles of behavioral therapy. The link that's attached here covers kind of an array of behavioral therapies that have been shown to work well with older adults who are experiencing depression. There's also bibliotherapy, and there's a quick link there that is some examples of what that could look like. Basically, bibliotherapy is the practice of reading self-help kinds of materials that allow older adults to kind of work through their own issues independently. But that has been shown to be very effective for dealing with depressive and anxious symptoms. Then, of course, there's a problem-solving therapeutic approach. And basically, this is, a time-limited, a short-term approach. The goal is, or the objective is basically to create action steps within a certain timeline where you can achieve a specific goal. So let's say maybe an older person is having some anxiety around downsizing and relocating from their own home into an apartment or into an assisted living or subsidized housing or something like that. or maybe transferring to a nursing home. So the process using a problem-solving approach might be, helping with the planning of what that experience is going to look like, getting used to the idea of relocating, prepping the person you're working with, prepping them for the move, helping them to sort things out and to pack. Sort what are they going to keep, what are they going to give away, what needs to be thrown away, what needs to be shredded, what can be put away in storage, or what can be passed on to family members or grandchildren or other family members, that sort of thing. And then helping with the actual move in and of itself, and then assisting with the transition of that move and following up and working with someone after the move has taken place and helping them get settled in and address any feelings or concerns or grieving of losses that they may experience in that moving process. So some of the common features of problem-solving therapeutic approaches are basically, the idea that this intervention is introduced promptly, it's timely, it's related to whatever the issue is that someone is struggling with. And it is, again, it's just time limited and very short term, and it's focused on accomplishing a specific task, like I mentioned previously, and it is meant to resolve any of the mental health issues that might be associated with change and that are impacting a person's life. So problem-solving therapy can be very useful with older adults. Similarly, solution-focused therapy has been shown to be very useful with older adults in dealing with depression. So solution-focused therapy is the approach, you might remember, that oftentimes incorporates the miracle question. So maybe asking the older person that's struggling with depression symptoms, for example, suppose you woke up one morning and by some miracle, everything you ever wanted, everything good you could ever imagine for yourself has actually happened. Your life has turned out exactly the way you wanted it. Think about that. What would that look like? So what will you notice around you that lets you know that that miracle has happened? What will you see? What will you hear? What will you feel inside yourself? How will things be different? So those are the kinds of questions that would be asked during solutions-focused therapy, and helping older people to imagine what life would be like in the ideal circumstances is really the approach that this intervention utilizes. And the essence of solution-focused therapy is really that the client is the expert, right? And the client is the one whose goals are important. Solution-focused brief therapy focuses on the solution that the client wants. It doesn't focus on the problem per se, and it doesn't focus on the history of how that problem, quote unquote, arose. It's really focused on the present and imagining the future as to how that might look. The key to success is knowing what you want with solution-focused therapy. And this really is an approach that fosters empowerment and is something that, again, has been found through research to be very effective with this population. This slide also has ECT, or electroconvulsant therapy, on here. This has made a comeback, in recent years, so I encourage you to kind of get up to speed on the way in which it's being practiced now, especially with older adults. There's also sufficient research that talks about interpersonal therapy and its effectiveness with working with older adults, especially with regard to depression. So interpersonal therapy, you might remember, is the technique that really was developed to manage 4 basic problem areas, if you will. It looks at unresolved grief, which sometimes looks like psychosomatic symptomology or manifestations, or when people haven't really dealt with losses or grief from previous times in their lives, and it's kind of a delayed reaction. Or it might have to do with role disputes. So anytime folks might be having issues with interpersonal relationships, or roles that can arise among significant people in their lives. It also is helpful for people that are dealing with role transitions. So for older adults, sometimes they really struggle with role transitions when it comes to maybe becoming a grandparent, or especially if a grandparent is taking on primary caregiver roles of their grandchildren. Or maybe they are themselves caregiving for an aging parent. So you can have an older adult whose parents are still alive, right? And they're taking on the caregiving role of their older parents or other family members or siblings, sometimes siblings, or their spouses. If their spouse is in need of caregiving, then that's a transition, a role transition that they're often struggling with. Or it might also be when a person is transitioning from the workforce, so they're going through retirement, and we see people working in the labor force longer and delaying retirement. So this can be a huge transition for people and give them, some challenges sometimes with their role and identity. And so interpersonal therapy can be very helpful in that situation as well. And then the 4th area is interpersonal deficits. So this has a lot to do with interpersonal relationships, again, with others in their lives, and kind of helping folks reestablish healthy, positive relationships that might be more sustainable and more functional, and using examples of good, healthy relationships if they had any from the past, and also using the relationship between you as the therapist and your older person as the client, and modeling healthy relationships through this interpersonal therapeutic approach. We also have research that talks about bright light therapy and phototherapy, and this might be something you're generally familiar with, especially for people that maybe experience SAD, seasonal affect disorder, but actually the research shows that bright light therapy can be helpful in not just SAD, but other depressive symptomology. And again, those video links are pretty short and sweet, and I encourage you to check them out as you have the time to do so. The other side of this slide talks more specifically about anxiety approaches, or rather approaches to dealing with anxiety, specifically with older adults. But the research shows that relaxation techniques are very effective to reduce anxiety symptoms with this population. The same with meditation and mindfulness. There's a lot of research now that shows evidence to support the use of meditation practices and mindfulness practices with older adults. Biofeedback is not uncommon to be used with this population, as well as guided imagery. So those are the primary evidence-based treatments for either depression or anxiety. This slide has even more evidence-based treatment, and I separated these out because these modalities are shown to be useful for both depression and anxiety, not just one or the other. So obviously for both of these conditions, medication is a very common therapeutic intervention that has been shown to be helpful with older adults experiencing symptoms of depression and or anxiety. Motivational interviewing is also something that has just more recently in the last decade or so moved from the promising list to actually evidence-based treatment with this population. And narrative therapy also has transitioned from a promising approach to an evidence-based intervention with older adults. And narrative therapy, just as a brief overview, is concerned with the ways in which people construct meanings in their lives rather than the ways they behave. So the central assumption of narrative therapy is that personal experience is fundamentally ambiguous. It's subjective. It has multiple interpretations, and these explanations, or in other words, the stories we tell ourselves, organize our experience and shape our behavior. So it's similar to like a self-fulfilling prophecy. So if we think about things in a certain way, it's more of an inclination that it will turn out that way, whether it's positive or negative. However, most often when we think more negatively, that's where the challenges come into play, right? Because that's where the focus is on self-defeating cognitions or thoughts and feelings. So the stories that people tell themselves about their problems becomes dysfunctional. And this is where narrative therapy can be helpful. So when the stories people tell themselves about their lives lead them to construe their experience in unhelpful ways, they tend to get bogged down with those issues and with those thoughts. And sometimes those problems are likely to persist as long as these unhelpful stories remain fixed or rigid. And it obscures more optimistic versions of those events. So problem-saturated stories, once they take hold, encourage people to respond to each other in ways that perpetuate the problem story that they're narrating in their minds. So narrative therapy uses narrative metaphors that focus on clients' understanding and experiences that helps to expand attention to allow them to consider alternative ways of looking at themselves and their lives and some of the things that they might be challenged with. So there's sort of this emphasis on rejecting normalcy and categorizing or labeling people based on the stories that they tell themselves. So narrative therapy encourages therapists to take a more collaborative, empathic position with strong interest in the person's story, and to search for times in a client's life or their history when he or she was strong and resourceful. And it uses questions to take a non-imposing, respectful approach to any new story put forth. Never label people, but instead treat them as human beings with unique personal histories. It also encourages us to help people separate from the dominant cultural narratives they have internalized so as to open space for alternative life stories. It's also encouraging to counter the way society convinces people that they are their problems. Narrative therapists try to get people to externalize their problems. The problem is the problem, not the person you're working with, not your client or the family. We're not playing the blame game here. We're helping people to see that whatever it is they're struggling with, that is the issue. It's not anyone or anything else that's a problem. It's not their fault. It's not their blame. It is what it is. So instead of having a problem or being a problem, we encourage clients to think of themselves as struggling against their problems. And just by having that change in mindset is almost like a paradigm shift for a lot of people, and it allows them freedom to think about their life stories and their histories in a completely different way. This approach often uses sparkling events, times when the people we're working with have maybe resisted the problem or the behavior in ways that contradicted the problem story. So anytime that adversities have been overcome, those might be thought of as sparkling events and can be used to transition those personal stories and life histories through a narrative approach. So again, this narrative therapy is really about reauthorizing the life story of the people that we're working with. And this has been shown to be, through research, to be evidence-based for working with older adults. Another very common evidence-based approach to working with older adults is traditional psychotherapy or brief psychodynamic therapy. And again, there are some videos. There's a video link here on this slide that you can click on to watch. And then, of course, cognitive behavioral therapy, which is very common, and different derivatives of CBT have also been researched and have been shown to work with older adults. And cognitive behavioral therapy is all about the relationship between thoughts, feelings, and behaviors, right? So if we can help people somehow change their irrational thought patterns or distorted thinking patterns, then we can change the feelings about things, which will ultimately lead to changed behavior. So the ultimate goal of CBT is to change both the emotional state and pattern behavior, to have it be more productive or more helpful in people's lives. And it's also really important to note, especially for CBT, but for many of these other approaches, which maybe I should have mentioned it earlier, you can really only use things like CBT with older adults who are verbal and have no major cognitive impairment, and they're not under the influence of drugs or alcohol or something like that. They must be able to think abstractly and analyze behaviors and discuss their feelings. So there has to be some level of competency in order to reap the full benefits of CBT. They should be somewhat self-aware and willing to self-disclose and sort of, actively participate in the process. So something to keep in mind. These are proven to work well with depression and anxiety, but the caveat is under certain circumstances. Someone with complete memory loss or advanced Alzheimer's disease is not going to be able to participate in cognitive behavioral therapy or probably narrative therapy or life reminiscence or life review or some of these other approaches because the cognitive capacity is not intact enough to participate effectively. The next approach that is on this slide is life reminiscence. And life reminiscence has to do with the process of remembering prior life events. And a lot of times this is focusing on positive or happy memories, happy experiences in life, things that really help people derive a sense of accomplishment and meaning, things that help them identify for themselves what their purpose in life has been. Did they make a difference? Did their life have meaning? So memories often serve as a source of great joy. So reminiscing about those memories and those positive experiences typically elicit happy feelings and a better mood and increased self-confidence and a sense of accomplishment and productivity. So being able to relish in life's accomplishments and purposefulness may contribute to the ability to achieve what Erickson talked about as ego integrity and feeling like you lived a life worth living, where you have a high sense of life satisfaction. So again, the focus is on positive events and feelings, and it doesn't attempt to resolve like lifelong conflicts or any unfinished business, so to speak. That's not what life reminiscence therapy is about. It's about focusing on the positives and things that really helped make a person feel like they have a sense of purpose. So so that's basically the essence of reminiscence therapy. It's specifically geared to guiding elders to remember events that reinforce the belief that they are worthwhile, valued human beings, and it is intended to improve an older person's mood or affect, but it doesn't necessarily attempt to achieve insight or to change perspectives on experiences. It's just bringing up those things in order to help them feel good, basically. And part of the research shows that when people feel better emotionally, physically they feel better too. So they go hand in hand. So life reminiscence is a very effective strategy to help older adults with depression and anxiety. Now, the last option on this slide talks about life review, which sometimes gets confused with life reminiscence, but I'm going to try to sort of separate out the ideas between life reminiscence and life review. So life review also deals with looking back on people's past lives and talking about different experiences that they've had. And it can be looking at good and bad things, but really life review is most effective when looking at those things in people's past that they're uncomfortable with, things that they maybe feel some despair or regret over, things that maybe they felt were like a waste of time, or things that contribute to a sense of despair, especially when thinking about it from Erickson's perspective. When people have not felt like their lives have been meaningful or purposeful, maybe they feel like their life was a waste of time and their life was just a waste. And so for people that are feeling that kind of experience, especially in late adulthood, life review can be an approach that can really help them by working through those memories of those experiences. So it's an opportunity to confront past guilt or shame and try to work to resolve those internal conflicts that people might experience and to reconcile any of those issues, make amends if possible. So sometimes people feel like they have unfinished business, maybe with family members or other relationships they've had in their lives. And so this is a process where people can work through those negative memories and negative emotions and help them reframe and accept those past events, or take steps to resolve them, like I said. So the goal for life review is to actually achieve some sense of insight or perspective, helping to put things into perspective rather. Sometimes that involves being able to see something from a different angle than when a person was actually going through the experience that's troublesome to them, and working with them to see it from a different light, and maybe that can help put that issue to rest for them. So life review is, again, really about helping older individuals come to a sense of peace with their past, or come to some sense of acceptance with their life, helping them to see how they've overcome things, helping them to see their strengths and how they've coped with hard stuff, and really just, like I said, kind of putting that to rest so that they can be resolved of those things that have been bothering them for a long time. So again, the difference between life reminiscence and life review is that life reminiscence focuses on more of the positive experiences and accomplishments in a person's life, things that have really given them a sense of meaning and purpose, and relishing in those and helping to affect change in mood or emotions or affect by remembering the good times. Whereas life review is an opportunity to look at the things that are hard and that people might have regrets about or feel despair over, and work with them to resolve unfinished business, quote unquote, or to find meaning in the experiences that they have had, and finding a sense of peace and acceptance for the experiences they've had and the role that they've played in their lives, and helping them to become the person that they've become. And now we want to just briefly look at some of the evidence-based treatments and interventions for people with dementia. This will actually be pretty short because we're going to spend more time on some of these interventions in our next lecture presentation and materials. But essentially, one of the primary things that we want to look at when working with dementia is preventative care, right? So if we can do what we can to minimize or delay the onset of any type of dementia, or minimize its effects on people's lives, that would be the most ideal thing, is to nip it in the bud before it can even happen, right? So some of those primary preventative care activities are things like physical exercise. We have a lot of research that shows the efficacy of physical exercise with older adults. Even if they're late starters to physical exercise, it can make a world of difference in their, not just their physical health, but their mental capacities and their mental health as well. So again, there's a link here that gives some just a quick video clip of the importance of physical exercise, specifically with older adults, and some of the types of exercise that have been shown to be most effective, including things like Tai Chi and the use of even video games or software programs like Wii that offers some very easy to use ways to get physical exercise, whether at home or in a congregate setting like a senior center or even in a nursing home. So physical exercise can be very useful, as well as mental stimulation. There is a lot of research that talks about brain development and brain changes as we age, and that basically if we don't use it, we'll lose it. So mental stimulation, even things like learning a new language or learning a new skill, maybe developing a new hobby, doing things like Sudoku or crossword puzzles or word finds. Any kind of creativity in arts is very helpful to the brain functioning and can help delay the onset of some types of dementia. And then, of course, there's the standard diet and lifestyle activities that people engage in, drinking enough water, and ensuring essential vitamins and nutrients are taken in every day. Those are also essential to preventative care for different types of dementia. Once dementia has been identified, of course, there are some medications that can be used to manage dementia symptoms. It is important to know that there really are, even in this day and age, there's really a very few, maybe 3 medications at this point that have been shown to be useful to slow the progression of dementia and increase neuron production. It doesn't cure dementia. It doesn't make it go away. It doesn't fix it. It really only slows the progression of the disease process. But medication can be useful for that. So it is definitely something to consider when working with older adults. And the more common approaches to treatment of dementia are really psychosocial interventions. A lot of times the traditional approaches aren't as effective because those approaches, like I mentioned earlier, really rely on people to still have their cognitive capacity intact, and it relies on memory and relies on communication skills and identifying feelings and being self-aware and having self-insight, those kinds of things. So those aren't always as helpful, especially as the disease process of dementia progresses. Those traditional approaches are less likely to be effective. So the most research has been used or has shown that things like validation techniques and life reminiscence to some extent can be very useful. And so I wanted to give you some information about validation therapy as an approach to older people experiencing dementia. And the important thing to remember with validation is that we want to remember that all behavior is need-driven. So it's an attempt to communicate something. So when an older person is acting a certain way or being repetitive or something, they are expressing a need. They just don't know how to express it differently. And so validation is a way to sort of go with the flow and be where the client is. And we hear that with some of the traditional approaches too. But what validation does is help us to let go of the logic. And what I mean by that is, rather than trying to reorient a person to time or place or even to whom they are, it's about respecting their reality and using their reality to understand what they're trying to communicate. Some of the principles of validation are to never argue. You will never win. It's a futile battle. That is, never attempt to orient someone with dementia to time or space. It's not going to stick. Their brain isn't functioning the way it used to, so they're not going to remember those things, and it might agitate them more because telling them over and over, what the reality is only going to cause more strife for them and confuse them more and agitate them. So never argue, never attempt to reorient, and help recognize or remember to recognize that retreating back to an earlier time of life might actually be an attempt for the older person with dementia to reestablish a sense of safety and security. They're remembering something even if they can't communicate it effectively. They're remembering a time where they had a sense of mastery or control over their environment. And so sometimes what we see in folks exhibiting different behaviors or moods related to their dementia experience is that need for control or a sense of mastery over their environment or over themselves, and they may know somehow, somewhere inside, that things aren't right, and they're trying to recapture that that sense of being in control from a previous point in time in their lives. Validation doesn't try to reinforce or extinguish any kind of behavior that might be perceived to be annoying or troublesome. That is not the goal of validation. However, you might see changes in behavior if a person's feelings are validated and enough to where some distraction can happen. So when validating, we are accepting behavior as an attempt to communicate a need or a thought, like I mentioned before, or a feeling, and we are trying to figure out what the meaning is behind that behavior. So the major focus, again, of validation is to maintain communication with the older person who's trying to express themselves, rather than actively resisting or trying to push them away or redirect them or reorient them. And it's also, again, about maintaining those relationships and communication and keeping personal connections intact, maintaining social stimulation rather than resisting or downgrading the cognitive decline of dementia or dismissing the older adult. So now I'd like to give you an example of what validation might look like by sharing a little case scenario with you. Okay, so this scenario describes a social worker at a nursing home who one day came across a resident demanding a train ticket at the nursing station.